All right, take two, everybody. Let's see if this one works. Sorry, I had to kind of reboot it. I'm trying to make sure that the audio is working for everybody. So I just,
Oh my God, I think I can hear you.
all right, there we go.
Yay!
Welcome. So I had you on Facebook. I could hear and see you on there, but I don't know if you have to invite me on that one.
I do, and I couldn't see quite how to do that. I can try again. If not, you can give me this and, well, let me just try. If that's okay with you,
Oh,
or
yeah,
do you
yeah.
want,
Oh, no, we're good. Yeah.
okay, let me just try here.
Oh, yeah. I'm just reading the comments here. Yeah. Definitely was working on my tan this weekend, so I'm trying to get my vitamin D for 80, I think.
Okay, let's just do the Instagram live and then I'll take this video and post it
Okay, and then,
to
yeah. And then,
to my Facebook live because I feel like it'll take a while.
okay. If not, I'll do a Facebook Live with you whenever it's convenient for your audience. So.
Okay, perfect.
All right. Well, good evening, everyone. I'm Dr. Michael Twyman. I'm a board-certified cardiologist focusing on heart attack and stroke prevention. Tonight, I have the honor to be chatting with Dr. Becky Lynn, a local OBGYN who focuses on women's health. So I recently had the opportunity to meet her in my office in St. Louis, Missouri to hear all about her practice. And tonight, we're going to talk more about women's health and definitely about optimizing women's sexual health, which I know is a topic that a lot of my audience is interested in. I've done a couple previous talks on men's health. And so if you want to see those, it's on my YouTube channel, it's on my Instagram TV. But tonight we're going to talk about the ladies. So Dr. Lynn, why don't you tell us a little bit about yourself?
Sure. Well, thank you so much for having me on. I am a gynecologist and I do specialize in menopause and women's sexual health, which I think is a very much overlooked topic. Women's sexual health is just as important as men's sexual health, but it doesn't get quite the attention. And I feel like a lot of women suffer with problems, but they're too embarrassed or ashamed to bring them up, or they don't know who to talk to. But about me, I'm an OBGYN. I run Evora Women's Health here in St. Louis, and we are a concierge gynecology practice. So that means that we spend a whole bunch of time with you, and we try to provide the services that midlife women, midlife and beyond, and younger, need under one roof.
Okay. And so how do women typically come to find your services? What kind of symptoms are they having when they're looking for you?
Yeah. So it's typically either menopause or sexual health. We also do weight loss. So some of the typical symptoms that we see in my office that are attributed to menopause are hot flashes, night sweats, low libido, painful sex due to vaginal dryness, weight gain, joint aches, brain fog. And most women know that menopause has everything in the world to do with hot flashes and night sweats, but they're not aware that it has to do with your libido, or it has to do with brain fog or short-term memory loss. Eat less, but just losing your estrogen around the time of menopause can increase your risk for insulin resistance and make it really hard for you to lose weight. So those are some of the classic reasons that people find me and come to our office.
Okay, excellent. Yeah, those are symptoms that I see in my female patients as well. And sometimes it's a chicken and egg type of thing where they come to see a cardiologist for their lipids or blood pressure, and then you talk to them about some of their symptoms. You're like, it's probably somewhat hormonal in nature. So and then I send them out to a doctor such as yourself that then kind of looks at that aspect. Or it's the other way around. They come to you talking about their menopause issues and be like, did you ever think about your heart health? Women's heart disease starts increasing, around the time of menopause. So, so we definitely kind of synergistically have those kind of patients overlap.
Definitely.
So
and we do a lot of checking of lipid profile. So then, that's not something that I manage. I would send them to you. Or even like heart palpitations are more common around the time of menopause. So, and like you said, cardiovascular disease is so much more common around that time that we need a cardiologist. And heart disease is the #1 killer of women.
Correct. Yeah. By far and away, way more than breast cancer. And even by,
Yes.
breast cancer is very important to get you screening for, but heart disease is still the #1 thing that takes out both men and women. So
Right.
that's one of those things that, test don't guess. Just because you're a woman doesn't mean you're necessarily low risk.
Right.
So what kind of workups do you do for these type of symptoms usually?
So typically there's not much of a workup if somebody's having a hot flash. It's really, you figure it out by history. If they're within a couple years of, if they're in their late 40s, typically the average age of menopause is 51. So if you come to me and you're in your late 40s or early 50s or even late 50s and you're having a hot flash, which is typically described as like this central feeling of heat that sort of rises up and your face gets flushed and you're really hot all of a sudden, and it might be followed by shivering, you're really cold. So there's not really a lab test or workup for that, but if you're within that age range, then we know it's a hot flash. Low libido is a little bit more complicated. Libido is really contextual. There's so many things that contribute to low libido. One of them is the loss or the lowering of testosterone in the menopause. So yes, women have testosterone, just not as much testosterone as men. And it starts going down in women's early 30s. And then by the time you're in your 50s, it's pretty darn low. So that's one of the things that we might check. A testosterone level when it comes to low libido, or we check a TSH level, or look for any chronic conditions that might be contributing to low libido. For other things, it's really mostly history. I always screen for anxiety and depression just by asking questions. Anxiety and depression are also commonly found around the time of menopause. It's a difficult time for women. It's when kids are getting older, maybe leaving the nest, and parents are maybe ill and requiring care. So really, I would say most of the workup is really done with a very thorough history. And luckily in my practice, I have the time to do that. So I can spend, an hour with my patients to really get at the core of all of the issues. For weight gain, we check a lipid profile, we look for diabetes, we check a hemoglobin A1C. We also do a HOMA-IR, which is a measure of insulin resistance. So we measure insulin, we measure your glucose, and then we can see if your body's really pumping out more insulin than it needs to be.
Excellent.
So that's what we do.
Could you share some of the common misconceptions regarding like hormone replacement therapy?
Oh gosh, yes. So, there's a lot of frustration out there in the menopause world, I think. So I'm going to have to go back in history. So I'm going to try and not make it too long, but in the early 90s, we thought that hormones were the greatest thing since sliced bread. Everybody got put on a formulation called Prempro. We thought that it decreased your risk for cardiovascular disease, but that was based on retrospective studies, so looking backwards. But the NIH paid for a huge study called the Women's Health Initiative, which looked at women on Prempro, and their primary outcome, what they were looking for, was to see if it decreased the risk of cardiovascular disease. They weren't really looking to see if it treated hot flashes or not. And they ended up stopping the study early because they found that women on Prempro had an increased risk for blood clot, heart attack, stroke, and breast cancer, and a decreased risk for osteoporosis and colon cancer. And that got so much media attention. Everybody got off their hormones. They were scared about them. And the world changed around the Women's Health Initiative. But what didn't get so much media attention is that when they broke down their study population by age range, so like 50 to 59, 60 to 69, 70 to 79, that women in the 50 to 59 age group actually did have a decreased risk of heart disease. And it just didn't get a lot of media attention. And even amongst physicians and treating providers, everybody was so afraid of hormones after that. But over the next 20 years, they've continued to gather data, and we have found that there is a cardioprotective effect from being on hormones, and it keeps your bones strong, it helps your brain, it helps lower your chances of developing insulin resistance. But during that time, since everybody got taken off their hormones and people were miserable, a lot of these sort of pop-up hormone places came about, and people started getting compounded hormones, which means made in a compounding pharmacy. And really, a compounding pharmacy is really should be reserved to make something that there isn't an FDA approved alternative. There was a big, push towards bioidentical compounded hormones. And what bioidentical means is that it's just the same chemical structure as your own ovaries make. So there are FDA approved bioidenticals. And since that study, we don't use Prempro hardly ever. There's really not a reason to use Prempro. We do choose bioidenticals, but there was a huge movement and really good marketing on the part of the compounding pharmacies and the providers that prescribe this. And they're really not better, and they're not recommended by the North American Menopause Society or the American College of OBGYN when there are safer alternatives. And there's also a big pellet industry. This is also not recommended by North American Menopause or American College of OBGYN. And I've seen a lot of women with super, super high testosterone levels on pellets in a dangerous range, but they make people feel really good. But the pellets, and even if every time I give a talk on hormones, I search the medical literature to see if there's any data on pellets, and there never is. And if you go to, I feel really strongly about this, by the way, if you go to the BioT website, there's a disclaimer on the bottom that says these pellets are not intended to treat or diagnose or cure anything. And so, I really strongly believe in science. I'm very much an academic physician, so I really do follow what we know, because when there are FDA-approved medicines, it means that those drug companies, which I know we think they're evil, but they have to prove to the FDA that the drug is safe and that it does what they say it's doing. Compounding pharmacies don't have to prove it's safe, and they don't have to prove that it's effective. And so, when there's an FDA-approved bioidentical, that's the one that I choose. So that was a long-winded answer.
Okay. But very, very detailed and very scientifically backed. So thank you. So you mentioned testosterone in women. Yes, women do make testosterone. So, I know testosterone is extremely important for muscle health. It's important for libido. So what other what other things that help with women to help optimize their sexual well-being?
Other things to help optimize their sexual well-being?
Testosterone, what about the benefits to women?
Oh, of testosterone? Yeah. So the main one where the most data is low libido. But it does also help build muscle mass. It's not going to make you build muscle if you're not lifting. You actually have to do the work yourself. And it also helps with fatigue. The data is not as strong on those two, but I see that in my patients, definitely. And it can improve insulin resistance. Testosterone does. So it has a lot of benefits, and I'm always like, we're so good at replacing estrogen and progesterone or estrogen alone, but the ovaries make testosterone also. So why are there so many products where we replace estrogen when it goes away? Yet there's nothing for women. There's no FDA approved formulation of testosterone for women, even though they need it. And where I see this a lot, and I think this is a travesty, is there are a lot of women who have their ovaries removed very young. For maybe they have the BRCA gene, that's a common reason, or maybe they have endometriosis. And we give them their estrogen back because they absolutely need estrogen for bone health, heart health, brain health. But we don't give them testosterone. And so they lose their sex drive. They're so tired and they feel awful. And so my hope is one day there will be a testosterone that's on the market for women, because we need one.
For sure. And what are your concerns about, super therapeutic or super high doses of testosterone in women? What are the side effects you've seen?
Oh, I've seen horrible side effects. So definitely facial hair, deepening of the voice. I've seen where the clitoris grows. It's called clitoromegaly. So the clitoris grows, and those things are permanent. We also see male pattern baldness and hair loss with too much testosterone. And we also see hemoconcentration. So that means you have too many red blood cells in your blood vessels. And so you're at higher risk for blood clot. And so we don't want that. So really, I've seen a lot of the fallout from high levels of testosterone in women.
It's mainly the conversion to the DHT, the dihydrotestosterone, causing the bald.
Yep, male pattern baldness. Mm-hmm. Yeah.
And then I definitely, check my patients for, their CBCs to look at what their hemoglobin levels are, because I tell patients, you want your blood to be like red wine. You don't want it to be like ketchup. And if you're on too much testosterone, you're pumping out more and more red blood cells, and your blood just gets really thick.
I like that analogy. I'm going to have to steal that for my own.
Yeah, you can seal it.
Yeah, perfect.
So usually we go about 30 minutes on this. We're going for about 20. So is there anything you want to share? And then we'll open it up to some Q&A.
Well, what do I want to share? I do want to share a little bit about weight gain and weight loss in the perimenopause, menopausal time, because it's so frustrating. And I see a lot of women who come in and say, I'm eating nothing and I'm exercising like crazy and I cannot lose weight. And I believe them. I think that most practitioners who don't have that training in weight loss are like, oh, you must be eating more than you're saying. There's no way you're really lasting that long at the gym. But our bodies are really designed to make us gain weight. They do not want to lose weight. And there's a lot of hormones that are released in our brain and in our gut that drive us to eat. And, there's a theory that fat in and of itself creates sort of an endocrinopathy, where the hormones that fat cells make are really keeping us fat. And so it's not all about, oh, poor willpower, someone who's obese. So it's just that they don't have any willpower. It's not. It's that their fat cells are working against them. So that's why we do a lot of looking for insulin resistance and whatnot, but also our weight loss program. It's slow weight loss because it's much healthier to do it that way, more likely to stay off. But we include counseling with a dietitian. We do a lot of strength training because building muscle helps increase your resting metabolic rate, which means that even just sitting still, you're burning more calories. So when women go through menopause, they become more fat and less muscle. And if you do nothing, you'll gain 1.5 pounds a year, no matter what. So we have a strength training component to our weight loss plan. We also have a life coach who helps motivate our patients, because a lot of people get frustrated and then they sort of fall off the bandwagon and they feel bad about themselves. And she really keeps them on track. And then we do weight loss medicines if somebody needs a weight loss medicine. And sometimes they really, really, really do need a weight loss medicine. It's not a reflection of low willpower. It's just that their body's working against them.
Right, and I know the new medicine, or definitely is going to prove this, that's the GLP-1 antagonist.
Yes.
The GLP-1 antagonist, I'd say so.
Yeah, those GLP-1s work incredibly well. We use a lot of Saxenda in my office, and people really, really lose weight. It's amazing.
So how do people reach out to you, and how do they work with you?
So to find me, I am currently at St. Luke's in Chesterfield. You just go to my website really to find me. It's evorawomen.com. So it's E-V as in Victor, O-R-A, women, W-O-M-E-N.com. You can sign up to see me. You can make an appointment via the internet, or you can set up a free 15-minute consult. I do those too. Or you can call our office, which is 314-934-0551. Because we're a concierge, we keep our practice small, which means that we always have time for you. There's never a wait in the waiting room. We spend all the time that you need. There's no limit to how many things we can discuss, like there is with typical insurance. And we offer same day, next day appointments unless we're out of town. But we're pretty easy to get into. You won't wait 6 months to see us.
Excellent, excellent. Well, I definitely thank you for your expertise and your knowledge sharing with our audiences. I'll definitely send you a copy of this. And somebody saying you're her doctor and you're great. So excellent.
Oh, thanks. Thank you. Hey, Kathy.
So we'll open it up to questions. We can stay on the topic of hormones or women's health or whatever you guys want to ask us. So Dr. Pauldron's logging on. So greetings. Thanks for joining tonight.
Hello. We're getting lots of hearts, but no questions.
I know it's always the waiting game. Yeah, we'll get the questions in a second. So,
I have a question for you, actually.
Sure. What you got?
So when you see menopausal women, what is your cardiovascular prevention? What do you talk to them about prevention?
So typically, I usually start around age 40 for most people. Younger if they have a strong family history, but I definitely do more than just the traditional total cholesterol, LDL-C, HDL-C, and triglycerides. Your body is a system. You got 60,000 miles of blood vessels, and you got about 300 to 400 different things that can cause problems with those blood vessels. So you got to go looking for it. But man is as old as his arteries is one of the famous sayings. So take an actual look at the arteries. When women go get screened for breast cancer, they get a mammogram or breast ultrasound or breast MRI, and they're actually looking for disease. Where in cardiovascular world, we generally wait till people have symptoms, until they're having chest pain, shortness of breath.
Right.
They're waiting until they're really late to the game. So I like to look way earlier. Atherosclerosis is a disease that typically starts in people's 20s, and it just progresses. It's endothelial dysfunction. It's the inner lining of the blood vessels getting scratched up. And if you don't fix that scratches, 7-8 years later, you're going to start developing plaque in the arteries. And there's a couple tests that I recommend people get, considering, what their risks are. But anybody over the age of 40 should probably consider a CT coronary calcium scan. It's a low-dose radiation CT scan that looks for calcifications in your arteries. You're only supposed to have calcium in your bones and teeth. It's not supposed to be building up the walls of the artery. So if you have calcium score of 0, you tend to be lower risk, but not 0. And then one test you can add on to it is an ultrasound of the carotid artery. A little bit different than the carotid duplex, which is looking at flow. That's looking at for more kind of severe disease. But there's a test called the carotid intermedial thickness test that measures the thickness. And the thickness of the walls of the artery indicate how much inflammation is in the artery. More inflammation, more likely you're going to be laying down plaque in the artery. So if you get your vascular age less than your biologic and calcium score of 0, you're good to go. Those are abnormal. There's some more advanced blood work you can do to kind of dial in, figure out what's driving that plaque in you.
Great. So it looks like we have a question about supplements.
Right.
Should I answer?
Yeah. It's supplements are supplementary for a reason, and this is not medical advice. This is all for educational purposes tonight. So, but I don't know exactly what supplements you necessarily quote recommend, but everybody's an individual. So I let you take your spin at it.
Yeah, so I really, really believe in eating healthy, and that if you eat healthy, you really shouldn't need a whole bunch of supplements. And I would be wary of, someone who tries to sell you every supplement in the book. There's a couple supplements that I do believe in. Vitamin D, especially in the winter. We are notoriously low on vitamin D, and you need your vitamin D for a variety of things, but mostly to keep your bones strong. And when you're menopausal and you lose your estrogen, you're more at risk for osteoporosis or bone thinning. It's better to get calcium in your diet, but for people who don't get much calcium, I think a calcium supplement is a good idea. There's not really many other supplements. It depends on if you have any underlying conditions that you might need, folic acid. That's more for younger women trying to get pregnant. But if you eat, it's always better to get what you need from food, natural food, than getting it in a pill form.
I definitely agree with that. So I got a question here. Does yoga help increase good hormones? I'll let you take that part, and I'll take the heart health part of it.
Okay, so yoga in and of itself doesn't really change your hormones at all. But let me tell you, I am the biggest fan of yoga. It is the greatest thing because it does so many things for you. It helps with flexibility, which you lose as you get older. Your joints become stiff. You really lose flexibility. It's excellent for balance. So as you get older, you don't want to fall. It's great for balance. It builds core strength. And it helps teach you to relax your muscles as well as building strength. So we see a lot of women in my practice who either have weak pelvic floor musculature, or pelvic floor musculature that's too tight. So when it's too tight, it causes painful sex. When it's too weak, you might leak urine and have incontinence, especially like with cough and sneeze or urge incontinence. And so yoga is really good for the pelvic floor. There are other things you can do for your pelvic floor too, but yoga is typically part of that. And then the last thing about yoga is it's great for decreasing anxiety. You know, we can throw a whole bunch of medicines for anxiety at somebody, but all medicines have side effects. There's no medicine out there that has zero side effects, unless maybe it's a vitamin or something. And even some of those can have side effects. But so yeah, it's really good for moods. And I think we live in a stressful world and we worry a lot. And especially over the last year with COVID, anxiety is, you know, through the roof, and it's hard to find therapists these days. And yoga really helps with that. And you can do it online. In fact, at Evora, of course, I'm a big proponent of it. We have a free yoga class. It's been virtual, but this month it's going to be live and virtual, and everybody's welcome to come, and it's free. So if you go to our website, you can find that too.
Awesome. Yeah. Yeah. For heart health, I look at more as the stress relieving benefits of, yoga and meditation. That deep breathing is very important in improving your heart rate variability, which is a metric of how much stress your body's sensing. And it's also just very good for, you mentioned, flexibility, balance. Definitely don't want to fall and break something as you age, but it's all about mitochondrial function. So the more the people follow me online know that I'm all big into circadian rhythms and focusing on making the mitochondria work more efficiently. Well, you need oxygen to make the mitochondria work efficiently, and yoga with the slow rhythmic breathing, you're trying to train your mitochondria. So I guess we have some magnesium questions here. So can you eat your way to a good magnesium level?
Yeah, I think so, because most people aren't magnesium deficient. So I think so, but I can't tell you off the top of my head what foods to eat. I'd have to look it up or ask our dietitian.
Yeah, mostly the dark greens is a good source, and but for people that get tested, your blood level of magnesium is not a great metric of what your total body stores of magnesium are. When I was more hospital based, your magnesium level, we want your blood level to look greater than 2 for any cardiovascular patient coming in, because when it was under 2, they tend to have more arrhythmias and had more issues in the hospital. So we use magnesium like crazy. I'm sure in your previous life is delivering babies and trying to prevent some preterm stuff, you're using a lot of magnesium, but magnesium is extremely important to stabilize cardiac membranes. And but most people can get a decent amount from their nutrition, and there are different versions of magnesium supplementation if you're having symptoms, leg cramps, palpitations. There's things that can be done for it.
Mm-hmm. Yep. And during pregnancy, those leg cramps are super, super common. We usually recommend potassium. But we recommend eating bananas, orange juice, you can definitely overdose on potassium pills. So I know you know that because it's a cardiac issue. So
yeah, it's hard to overdose on the magnesium ones. You're going to get really loose bowel movements, and you usually stop before you do anything damage from that. But yeah, you definitely get into trouble taking a lot of oral potassium. So definitely be working with somebody if you're going to be supplementing with oral potassium. Well, are there any other questions coming in? If not, I'm going to let Dr. Lynn go, and thank her for her time. And we'll be doing this again sometime soon on her Facebook Live.
Yes.
This video is going to be recorded. This will be on my TV. I'll share with Dr. Lynn, and we'll put it up on our other social media platforms as well. But I thank everybody for their time and attention tonight. And next week I'll be back doing Ask Me Anything. It'll be over any biohacking or heart health related topics, and then we'll figure out something to do the following week. So. Again, thank you very much for joining me tonight, and have a great week, everybody.
Bye-bye. Thanks for listening.
Yeah.